Good afternoon. We'll be starting our instruction course on cataract comorbid capsule, where we'll be trying to discuss the several scenarios that we as cataract surgeons face when there are other comorbidities inside the eye, like corneal issues, like retinal issues, or trauma involved. And we have a tremendous stellar faculty with great experience, Dr. Vandanath from Raghudeep Eye Hospital, Dr. Rajesh Fogla, who needs no introduction, Dr. Shamal Dwivedi, retina surgeon at Raghudeep Eye Hospital, and myself, Dr. Shail Vasavda. So at the outset, I would like to invite Dr. Vandanath to teach us about how to deal with uh, when there is a cataract as well as a pterygium inside the eyes, how to handle that, which one first, which one second.
Thank you, Dr. Shell, for including me in this instruction course. It's an honor to be here. Good afternoon, everyone. We know that cataract surgery has now become a refractive surgery, and we are targeting the spherical equivalent very accurately. But what when we have some lesion on the cornea? And a very irritating lesion like a pterygium. So if you have a patient with a pterygium who you need to operate the cataract on, how do I know whether this pterygium is going to impact my calculations? So the most important evaluation is the preoperative evaluation, where we begin in detail, not only examining the cataract, but also the pterygium for its size, grade, because all this is going to impact the biometry and the choice of IOL. Go back to being a resident, don't forget your history, find out how long this patient has had the pterygium, whether he has noticed, whether it's progressing. Find out the vision expectation of this patient, because we have now crazily accepted that we need to be glasses free at all distances. So we have to counsel the patient accordingly. Status of the fellow eye is the most important. What is the fellow eye like? And of course, I cannot undermine the emphasis of counseling. So there are only three options when you're tackling this kind of a scenario. One, where you only do the cataract, leave the pterygium alone. Second, do the pterygium first, and after a decent period has passed of a few weeks or a few months, then do the cataract. And third is combine the cataract with the pterygium surgery. So option one, and these are our own cases which I'm sharing with you, and how we did the decision making in these cases. This is a 76-year-old gentleman, a very sedentary lifestyle, who wanted only a cataract surgery, doesn't drive. And if you're only going to look at the cataract, you may just miss this, thin atrophic avascular pterygium, and the patient knows that he has it since many years, and he is okay with it. He wants nothing to do with the pterygium, and there's a decent cataract. So the keratometry readings are the most important. Ideally, we would do it with more than one keratometer to see if it is repeatable or reliable. And we know that all pterygia induce some amount of astigmatism in the eye, so we want to know the magnitude of the astigmatism using whatever keratometry that you have, but ideally two keratometry readings which are in sync with each other. You also want to know the regularity of this astigmatism, so you must have at least a topography, if not the other imaging, Scheimpflug imaging techniques. So what we do is we would ideally do a manual keratometry ourselves, because that is what we do ourselves, in addition to a topography, to find out if there's a regularity and see if there is a good bow tie appearance. Now in this case, this patient had a 1 diopter of astigmatism, not a very large amount of astigmatism. But if you see this, astigmatism looks a bit irregular, and this is the aberrometry profile. Not only does the pterygia induce astigmatism, but they also cause higher order aberrations like coma and trefoil. And these are the studies that have shown that they have a significant influence, and these higher order aberrations can degrade the quality of vision to a large extent. So if I have an irregular astigmatism where two of the readings are not in sync with each other, and I may not be able to accurately predict the IOL power, I'm going to counsel the patient for an ocular surface disturbance as well and long-term lubricants, but I will also not go in for an aspheric. A multifocal toric is a no, because the amount of astigmatism is not that high, and therefore we would advise a spherical IOL for this. The second option is a stage surgery, where by default or where it is absolutely mandatory, where you're not getting keratometry reliable readings, you will go for a pterygium surgery first. And these are the cases where you advise a pterygium surgery first. Such a large pterygium is going to cause higher order aberrations, is going to cause as a high astigmatism. So do a stage procedure, and we always do a pterygium surgery with a conjunctival autograft. A method that I have learned from Dr. Fogla himself. Do these markings and see that you get only the thin conjunctiva and no tenons along with it. And using tissue glue without any sutures, we get very good outcomes. And in our hands, we have had hardly any recurrences when we do a conjunctival autograft. So the stage surgery, it has been known that they reduce the astigmatism and the higher order aberrations. These are the studies. This is the lady whom we operated. She had a fleshy pterygium, and for cosmetic reasons also, she wanted the pterygium surgery first, and we did advise it. So this is the pterygium that is causing a very high astigmatism, almost nearly a 3.75 diopter of astigmatism, with higher order aberrations like coma and trefoil. And we operated her with a conjunctival autograft. Not only did her astigmatism go down to a 1.75, and which we could treat after 3 months of the pterygium surgery, we went in for a cataract surgery. And we planned a toric IOL because you can see it, right? Yeah, yeah. Yeah. So we planned a toric IOL, and with a very good outcome. So at a glance, if pterygia are small and do not impact your keratometry readings, they can be left alone. If they are large enough to adversely affect K readings, remove the pterygium first and then plan, but wait at least for 6 to 8 weeks before planning, because the cornea topography keeps changing during that time. This is a no-brainer. This was a 58-year-old female. This is a recurred large pterygium with a very poor vision. She came to us for cataract because someone told her that there is a cataract now that you need to get operated. And definitely we planned a stage procedure with a phone call to Dr. Fogla when I'm in dire need for advice for this surgery. He said, there will be scarring, look out for scarring. This is going to be a large conjunctival autograft. This is the 1 week post-op picture. We could wait for 6 months for the cataract surgery for this patient because the corneal topography was very irregular immediately after the surgery. But after the surgery, it became quite regular. And we operated her. From CF 1 meter, she improved to 6/18. So she could pull on till we did her cataract surgery. Kept a close watch on the follow-up and kept assessing the cataract, and long-term gave lubricants. This was a very difficult case. A very active businessman, high-flying, absolutely did not want a cataract, did not want the pterygium surgery. He came to us only for the cataract surgery. Okay. However much we tried to counsel him, the other thing notable was that his mesopic pupil was only 2.5 millimeters and maximum pupillary dilatation was 5 to 6 millimeters. So he didn't even dilate very well. The other confounding problem was, and this is the importance of the other eye assessment, even if it was not operated at your place, the other eye was operated elsewhere with you can see those rings in the center of the pupillary area. It was a multifocal IOL. And best corrected was only 624. We did a posterior segment OCT to find that he has a full thickness macular hole in this eye. So now we are operating his better eye with which he was functioning. And ideally, this should not have been a candidate because if you can see nasally, there is a pterygium as well in this eye. So we couldn't get the aperometry profile. We couldn't capture it because of the large pterygium. So this is the Scheimpflug imaging. And if you notice, can you see this arrow? This dotted line is his pupillary area, and within the pupillary area, there is some semblance of a bow tie appearance. And this is the topography image. And 2 readings, both in my Scheimpflug and in the topography, both the readings on the cornea showed a 5 diopter of astigmatism, and both the readings were absolutely in sync with each other. So 2 keratometry readings were absolutely accurate. What best can I do for this patient? I want to reduce the amount of his astigmatism. We did go ahead using the Barrett toric calculator, and this is what we implanted, a T9, and he had best corrected of 6.6 visual acuity with hardly any residual astigmatism, and very happy with this eye. So we needn't be pressurized to put a multifocal IOL when you know that he can land up in great trouble with a multifocality. The third option, we caution, and we do not like to do this. We don't like to combine a pterygium with a cataract surgery, only in very dire special situations where the cataract is very mature and the pterygium is going to hamper your vision. So we do the pterygium and the cataract in the same sitting. There is possibility of refractive surprise. And the use of steroids after the cataract surgery can delay your corneal healing. So usually we do not go in for this combined surgery. In conclusion, ocular wavefront aberrations constitute the most important part of the optical quality of the eye, and pterygia lead to deterioration of the quality of visual performance, and they cause refractive and topographic changes in the cornea and increase the ocular wavefront aberrations. Thank you so much for being present in the audience. Thank you so much.
Thank you, Dr. Vandavan. That was an excellent presentation and lot of take-home messages. I think the most important take-home message that I can take from it is that like in any two diseases are coexisting in the eye, choose which is the more, first decide which is the more severe of the two diseases. So if you find that the pterygium, like Dr. Vandaban mentioned, is significant and is likely to affect the outcome of your other surgery, first try and handle or tackle that first surgery by getting rid of the pterygium, making sure that the cornea is stable. And I would go to the extent of saying that it's no harm waiting 1 month extra. So don't be in a hurry to operate the cataract. Wait at least about 2 to 3 months before doing or thinking about anything else. So that's an excellent take-home message. And I think in today's time, what Dr. Vanna correctly mentioned, combining pterygium with cataract surgery in today's time is not probably an idea to keep in mind or to discuss even, because both are very different surgeries, and your cataract surgical outcome is going to be significantly affected by your pterygium surgery outcome as well when you do both together. So I think we would like to strongly discourage the audience for using the third option. Thank you very much, Dr. Mandavan. Now moving on from right in front of the eye to right at the back of the eye, and India being the diabetic capital, we have so many diabetics who are undergoing cataract surgery. And although most of them don't seem to have any major, retinopathy or retinal diseases, some of them do have pre-existing retinopathy with significant cataract. And I would request Dr. Shamal Dwivedi to throw light on us as cataract surgeons from a retina surgeon's perspective as to what and how we should be dealing with such patients who already have existing retinopathy and macular edema and present with significant cataract.
So good afternoon, everyone. And thank you, Dr. Shail and everyone, for allowing me to present on this podium. So these are my financial disclosures, and I'll be discussing on diabetic eye disease dealing with cataract and diabetic macular edema. So India is set to become a diabetic capital by the end of 2030, and prevalence of diabetic is 10.8% in rural population, and prevalence of diabetic retinopathy is 12.2 in rural population, which doubles in the urban population. So 98% of type 1 diabetics and 60% of type 2 diabetics will have some kind of diabetic retinopathy, and 53%, around more than 50% of type 1 will have a proliferative eye disease. So it is very important when you take a history of the patient to know whether the patient is simply a type 2 diabetic or a type 1 diabetic. So now we come to our main discussion, that is treating cataract and DME together. So there are two approaches for cataract and DME. The first approach being the conventional approach, in which we try to treat the diabetic macular edema first by giving appropriate intravitreal injections or lasers, and do a cataract surgery 2-3 months later once the macula is absolutely dry. And the other approach is the combined approach, in which we treat cataract and diabetic macular edema with appropriate intravitreal injections. So these are some candidates who are good candidates for combined approaches. They are patients with advanced cataract in which we are not able to see the retina. Those young diabetics with posterior subcapsular cataract having excessive glare and who would be facing difficulties in their day-to-day life with driving, and certain patients with comorbid conditions or disease in which they may not be able to come to the operation theater again and again. So, according to the study conducted by the Journal of Cataract and Refractive Surgery, it has been said that nearly patients undergoing cataract surgery, diabetic patient undergoing cataract surgery, worsens diabetic macular edema is worsened in about 25 to 60% of the cases. So if we go with the cataract surgery of the patient, pre-operative evaluation is utmost important, and it goes without saying that counseling is one of the foremost part of this thing, and giving a proper chair time to the patient and talking to them and making them understanding their own disease is very, very much important. And of course, a good glycemic control, and there should not be any infection for any patients who are undergoing any cataract surgery. So again, this goes without saying that in-depth clinical examination or the evaluation is also very much necessary. I would emphasize on 2 points that gonioscopy is a very important factor to rule out any surprises, where we can sometimes miss the neovascularization in the angles in diabetic patients, which may lead to dreaded outcomes later on. And the other thing to incorporate in diabetic patient is to do a pre-operative OCT to rule out any diabetic macular edema. So just to refresh our memories, diabetic macular edema is the accumulation of excess fluid in the extracellular space, and the picture looks as you see on the screen. So there are various diabetic management options ranging from anti-VEGF agents to laser photocoagulation and to surgery. So now we come to the real world scenarios. Our team was involved in a multi-centric trial which concluded that dexamethasone implant is a valid option for treating diabetic macular edema with cataract in treatment-naive eyes. So here is a gentleman who presented to us with an advanced cataract for his right eye and a big diabetic macular edema. He was subjected to cataract surgery with a dexamethasone implant, and at the end of 3 months, he's still maintaining a decent visual acuity at 6/12 with though some amount of spongy edema, but he is doing very well. The next patient presented with a massive DME and an advanced cataract, and he too underwent cataract surgery with diabetic macular edema, and he is also maintaining a very decent visual acuity. This patient is the breadwinner of the family, one-eyed, and he is the only sole driver of the family. So he is very, very happy after getting a dexamethasone implant, and he is still able to drive with little bit of difficulty. So this is how a combined approach is performed. Cataract extraction is first done, and once the cataract extraction is done, an IOL implantation in the bag is recommended, followed by a dexamethasone implant in the inferior temporal quadrant, and we need to make sure that the implant goes into the vitreous cavity which is seen through the pupil. So he is a one-eyed gentleman. His right eye is almost a burnt-out retinopathy and a lot of tractional component, and he is hardly having any vision for the right eye. And the left eye is presenting with a diabetic macular edema and a cataract. We went ahead with the dexamethasone implant and the cataract surgery, and we were very happy to see that he regained his normal visual acuity, and the foveal contour was beautifully restored. So this patient further subjected to some focal and grid laser. The left one being the pre-operative profile of the patient, pre-operative fundus photo, and the right eye is after the focal laser, and we can see a beautiful resolution of the hard exudates, and to our surprise, the patient has not had a recurrence after this focal laser. So this is an interesting case. So the left picture is the pre-operative picture of a gentleman who presented to us for a cataract surgery, and we did a pre-operative evaluation, and we found everything to be normal. The only positive finding was his diabetic mellitus type 2 since 18 years. Except that, no other positive findings. And we went ahead and did a cataract surgery, and we were surprised to find that he developed macular edema for both of his eyes, right more than the left. And then we subjected the patient to fundus fluorescent angiography, and at that point of time we realized that he does have some sort of diabetic component in his eyes which was missed preoperatively. So we went once again with the dexamethasone implant, and the foveal contour is wonderfully restored with a normal visual acuity. So this gentleman is a gentleman with a chronic kidney disease, and he had undergone a pan-retinal photocoagulation years before, and he actually did not go to any follow-up after his pan-retinal photocoagulation. He was referred by his nephrologist for an opinion, and we could see that pointer. Okay, I got it. Fine, that's okay. Which is the third? Okay, so if you see, we can see a neovascularization over here in the right eye, as well as a neovascularization for the left eye. This is very well seen in the red-free photograph over here and right over here. So this patient was not a good candidate for dexamethasone implant, and thus we went ahead with an appropriate anti-VEGF injection. He also did have a DME, so we went ahead and treated his left eye first with the appropriate anti-VEGF. And after the anti-VEGF treatment, we can see for his left eye that the neovascularization has vanished totally. And we further topped up this patient with some aggressive PRP, and the patient is doing very well. So this was his left eye which we treated, and before we could treat his right eye, the right eye already landed up with a vitreous hemorrhage, which we are still following up, and if required, the patient may land up with a surgery for his right eye. So this left eye was done on time. So there is this is one more one-eyed patient who presented to us with a vitromacular traction, one-eyed and quite disabled patient who had some macular edema and a vitromacular traction. So this patient had to undergo a cataract surgery along with the vitreoretinal surgery. So first the cataract surgery was performed. The wound was sutured to make sure that the vitreoretinal surgery can be performed in a proper way, and 3 pars plana vitrectomy was started. So the vitreous is stained with the triamcinolone and it is trimmed, and later on, once the vitreous is trimmed, we went ahead and injected the brilliant blue dye, and under the brilliant blue staining we did an ILM peeling for the patient. So after the ILM peeling, the patient was topped up with some laser, and we were very happy to see this type of outcome with almost near normal foveal contour and patient maintaining a beautiful visual acuity of about 6/12. So this is my last case, and this case is a VMT and diabetic macular edema along with the hard exudates, and this is the left eye, this is the right eye. So we went ahead and gave a dexamethasone implant to this patient, and the edema got settled, but we can see the plaque of hard exudate just beneath the fovea, which was the main factor reducing the vision of the patient. So we had to subject this patient further to a vitrectomy, cataract and vitrectomy, of course, and we are trying to remove the posterior hyaloid and the ERM above it, and later the same way as I showed you in the previous case, we went ahead with the brilliant blue staining. We went ahead with the BBG staining and did an epiretinal peeling. Again, finally we closed the case after doing some top-up laser. And we were very happy, as well as the patient was very happy to see the outcome, maintaining a beautiful visual acuity and total reduction of the hard exudates. So my take-home message is counseling is extremely important in the patient, because it is the patient's disease, and the patient needs to know what he is supposed to undergo, what care he needs to take, and we are helping him to reduce the burden of his own disease. So counseling is an extremely important part. The other one being the tailored approach, customized approach for each and every patient. So one shoe does not fit all. So it is something like that we need to take care, and very close follow-up and working with a retinal colleague is of utmost important. Thank you very much for your attention.
Thank you, Dr. Shamal, for that excellent array of cases. I think plenty of take-home messages. The first important take-home message that I got was the so-called normal case that you showed, which flared up immediately post-cataract surgery, and that is something that all of us dread. And I think what you correctly showed was that although the OCT was normal pre-operatively, there must have been microaneurysms or few dot plot hemorrhages which were probably missed, which you, like you nicely showed, just 1 month post-operatively when you did the FFA, you saw the diabetic retinopathy leakage is already present. So don't take cataract surgery in diabetic patients lightly. Quite often with a relatively dense cataract, it may not be possible to see the retina very well. So take the help of your vitreoretinal colleague. The other thing what I also learned from your presentation was that now it seems that more and more vitreoretinal surgeons are preferring a dexamethasone implant, particularly when combining it with cataract surgery. And I see that quite logical as well, because the steroid component will also help to improve the cataract surgery outcome, and has a longer duration of action. But I think your last case taught me a lot more, that if you find that the patient is one-eyed, or the retinal condition requires first stabilization before you can decide what form of further management this patient is likely to require, then don't be in a hurry to combine the surgery straight away. Just operate cataract with an injection. First, let the retinal surgeon take his time, treat him with whatever ways he wants to. Like in your case, you showed treating it with an injection. And once you found that things are stable, but he still requires vitreoretinal surgery, so therefore the patient is also now more mentally prepared in the 1 to 3 months that he's undergoing retinal treatment, that he has two separate diseases. Because then otherwise everything comes up that after the cataract surgery I required the retinal surgery. So I think these are some very, very important take home messages that I would take back. And I think the most important is working in hand with your vitreoretinal colleague. Don't hesitate. You can never under refer to your colleague. You can never do that. So I think it's my pleasure and honor to invite Dr. Rajesh Fogla sir for the next talk. And I think all of us are going to learn tremendously from this talk in how do we deal with a cataract with an corneal endothelial disease. So I think that's a very good option, and we have some limited experience in fine ERMs of doing EDOF, and they seem to be working quite well. So I think we should be able to do now more and more in these borderline cases where you feel that maybe a trifocal is out of question. So I think this is likely to be in the future. Yeah.
I think it should have come. Check. Ask him to check there.
Yes, please.
Try that side.
So dexamethasone implant is a good choice in treatment naive eyes. So if the patient has been previously treated with an anti-VEGF, I would still go ahead and treat the patient with anti-VEGF and not with the dexamethasone implant. And right now, if we are combining any cases with the cataract surgery, we would go for dexamethasone implant. But otherwise, I would use the anti-VEGF. And we have lots of studies like RISE and RIDE, and lots of studies saying that aflibercept is the king of anti-VEGF right now and approved for diabetic macular edema. So if a patient does not have a cataract surgery, if the patient does not have a significant cataract, I would still go ahead and do the anti-VEGF injections. But the anti-VEGF injections would be a big load because repeated injections, it's not cost effective. So that is the reason many patients still come and ask to us, instead of us giving an option to them, they come and ask for the dexamethasone implant.
No, connect to VGA and see sometimes.
So topical non-steroidal anti-inflammatory are useful up to some extent, but in some cases of spongy edema where there is no subretinal fluid, or where there is no in a very very minor or spongy edema cases, I would try giving a non-steroidal anti-inflammatory drug. And in special in cases who they does not want to take any injection, in patients whom the visual acuity is quite good, so I would try using them and delaying as much as possible. So so I keep them on for an anti-inflammatory agent for about 6 weeks, not more than 6 weeks. And if they do not respond within 6 weeks, they are not likely to respond further.
Good afternoon, everybody. At the outset, I would like to thank Shail for making me part of this instruction course. I'll be talking about cataract surgery in eyes with Fuchs dystrophy, no financial interest to disclose. Fuchs dystrophy is usually bilateral, characterized by gutted formation, thickening of the DM, loss of endothelial cells, has autosomal dominant inheritance with a slight male preponderance. And if you're not very careful when you're examining your patient on slit lamp and you focus on the cataract, this can sometimes be missed. You have to specifically focus your slit lamp onto the endothelial layer of the cornea and look for these orange peel kind of appearance. You can look at the guttae on retroillumination as well. And specular microscopy shows you the dark areas. And if you have anterior segment OCT, you will see an increased central corneal thickness. And a thickness, the decimus membrane will also look double layered, duplicated, bright, high reflective, and you can see those bright specks on the endothelium. Patients will typically come with early morning blurring of vision, glare at night, which are again coexistent with cataract as well. Sometimes these can be attributed to the cataract. And because of the combined problem with the cornea and the cataract, they can present early. So the decision will be that whether you want to do the cataract or you want to do a combined surgery. With the advent of the Scheimpflug imaging, you can even use the pentacam to try and ascertain, because sometimes when you have the central corneal edema, the posterior corneal curvature gets affected more before you start seeing changes on the anterior surface. So looking at that posterior elevation where instead of the cornea, the cornea is getting, the posterior layer is getting depressed towards the anterior chamber. That can also help you identify and also stage the procedure. That means you can know that the patient is worsening over a period of time if you do serial pentagram imaging. A normal attrition of the endothelial cells varies between 0.3 to 0.5%. You do get an 8 to 10% endothelial cell loss when you do cataract surgery. And usually in cases with compromised endothelium, you tend to do the soft shell technique. And the study published back in 2005, where they used pachymetry as a cutoff, 640 or more, they found that the eyes which had a thickness of more than 640 more frequently required keratoplasty compared to eyes where the corneal thickness was less than 640. Advantage of doing a cataract surgery alone is that the patient does not need to use medications for a longer period of time. All the complications associated with endothelial keratoplasty is not there. They need to come less frequently to the clinic for checkup. And the disadvantage is that the vision deteriorates as the Fuchs dystrophy progresses. If you have to do a cataract surgery, you can choose the technique depending on the expertise of the surgeon. It's not necessary that you have to do a phacoemulsification all the time. Sometimes if I have a patient with compromised endothelium and a very hard cataract, I would resort to doing a SICS on an extracapsular surgery rather than trying to do a phacoemulsification. If I have eyes with very shallow anterior chamber, hard cataract, compromised endothelium, doing a decompression procedure like doing a limited pars plana anterior vitrectomy helps you open up the space and gives you more working space to perform the surgery. And taking into consideration that patient would require an endothelial keratoplasty, you choose a hydrophobic IOL because hydrophilic IOL can get opacified with air or gas tamponade. The lens power selection also, knowing that the hyperopic shift that can occur with endothelial keratoplasty, you will choose an IOL that is +1, which gives you -1, -1.5 postoperative refraction, which will offset the hyperopic shift that you see with endothelial keratoplasty. During surgery, make sure that you use sharper knives. So for me, if I'm doing a patient with compromised endothelium, I know that the decimus attachment is not as tight as normalized. I will make my paracentesis first, fill the chamber with viscoelastic, make the eye nice and firm, and then I'll make my other paracentesis and the main incision. Because if the eye is soft and you're trying to make your incision, Usually you cause a little bit of DM detachment at both the side port and the main incision, which can progress either during the surgery or in the post-operative period. Use BSS for irrigation. In these eyes, avoid intracameral medications because we are so used to using for dilatation, for antibiotics. So these are things when you have an endothelium that's not working well. Using intraocular solutions, you have to be very careful what you're placing inside the eye. Instead of hydrating the wounds at the end of surgery, I would rather, if I have a leaky wound, I will place a suture. Hydration would work when normalized here where the decimus is loosely attached. If you hydrate, there is a possibility that any detachment, you can make it progressively worse. You can always leave a small mid-size air bubble post-operatively because this air bubble will help, if there are any small DM detachment, it will help reposition them and provide them tamponade. Need to use steroids for a greater frequency because if you have compromised endothelium, you need to keep the inflammation to the minimal. You can use topical 5% sodium chloride in the post-operative to tide over the a little bit of corneal edema that can occur after the surgery. If you're using steroids more frequently, monitor the IOP because raised IOP can also result in the corneal edema getting worse. And do an anterior segment OCT if there is edema to identify DM detachment, which can be seen very well on anterior segment OCT. If you do get corneal edema, don't panic. At least 8 to 12 weeks it can take to resolve because I get call from surgeons who operate and within a week they want me to do a DMEC for the. So I tell them, at least wait for 8 to 12 weeks, unless you're pretty sure that you have removed the DM during surgery. Then there is no point in waiting 8 to 12 weeks. Do an anterior segment OCT and look at the serial pachymetry. That means you have a patient, explain to the patient what the position is, do a ASOCT map, look at the pachymetry values or do a Scheimpflug imaging. And then every week when the patient comes or you're reviewing it, do the pachymetry again. If you see your pachymetry is getting better, then you know that the eye is improving. If the pachymetry is not getting better or if it is getting worse, then it is likely that this cornea may not improve over a period of time. There is increased risk of endothelial failure if there is presence of posterior folds or epithelial edema. You see a lot of the guttae which extends all the way to the periphery. Sometimes you get fuchs, the guttae are only limited to the center, but the peripheral cornea looks fine. Those are eyes where the edema will resolve. But if you have guttae going all the way to the periphery, then maybe doing a combined surgery would be much better. So cutoff would be that if your PAC is less than 650, but cell counts more than 1,000, maybe you can just do a cataract surgery alone. If your PACI is more than 650, but cell counts are between 800 to 1,000, these eyes are at a greater risk of developing corneal edema. So you need to discuss with your patient and figure out whether they would be comfortable doing a sequential surgery or whether you would go ahead and do both at the same time. But if the cell counts are really low, then you can plan for a combined procedure. Now, sometimes I find that if you see a post-keratoplasty eye where PKP has been done, the cell counts are usually in the range of 600, 700. And then in those eyes, we go and do a cataract surgery, the cornea remains perfectly fine. But those are, if low cell density, but those are normal cells. And they have less intracellular junction, so the amount of fluid that can leak into the cornea is much less. Here you have abnormal cells with a lot of dead cells in between, which allow more fluid to leak into the cornea. So the cells are not able to pump back the fluid. So that's where the difference is between a low cell count in a post-keratoplasty eye doing well, but here, even with cell counts of 800 to 1,000, the cornea can fail. What you can do if your Fuchs dystrophy changes are limited only to the central 4 millimeter area, you can just do a stripping of the decimus in that area and allow the peripheral endothelial cells to migrate, something which we rarely see in our clinical practice. The other procedure we can do is DMEC. A DSO is something which is done under viscoelastic. You use a microforceps, initiate a break in the decimus, and you just do like a capsular excess, you do a decimeter excess, but only in the central 4 to 5 millimeter area. That's practically in the visual axis. But remember, you have to tell your patient that immediately after this procedure, there's going to be edema. They're going to a drop in the vision, which can take anywhere between 2 to 3 months to improve. Use of Rho kinase, topical Rho kinase inhibitors can help speed up the resolution of edema, but the patient should be prepared that it will take time for the edema to resolve. Advantage is that you need to use steroids for a long time because there's no risk of rejection. Disadvantage is that in 3 months, if it doesn't recover, then you'll have to undergo a DMEC procedure. So this is one of the papers published back in 2019 where they showed good results with DSO combined with use of topical ripasudil. But when you have extensive changes like that, you can do any of the endothelial replacement procedures, whether you are DSEC, ultra-thin DSEC, or DMEC. These have replaced the traditional penetrating keratoplasty. They give more predictable refractive outcome, faster visual recovery, and lesser risk of rejection. Studies have shown that combining cataract surgery with a DMEC procedure does not alter the success rate or the outcome of DMEC surgery. This is one of the patients where we have done a triple procedure in one eye, then we went ahead and did in the other eye, and you can see that both the eyes look great and they have good endothelial cell count and good visual outcome. This is again another patient after the cataract surgery, non-resolution of edema, where we went ahead, did a DMEC, had a good outcome. Phakic eyes, young patients with Fuchs who can present with this, you can do a DMEC first, let that resolve, and then the patient can come back, and whenever the cataract develops, you can do a cataract surgery. So that's another option, because sometimes in Fuchs who present early where the cataract is not present, you can do a DMEC first, and later on, the refractive outcome of those surgeries are better, because then you can plan whether you want to put a toric IOL, EDOF IOL, or a multifocal. Whereas an existing pseudophakic, sometimes you may not venture out because you don't know what the final K value will be or what would be the final astigmatism. So a lot of surgeons are now moving on to doing a sequential procedure where they do the DMEC first and then follow up with the cataract surgery later. The edema, the hyperopic shift is because of, in DMEC, because of the central edema resolving faster than the peripheral edema. Because of the faster resolution of central edema, it makes the posterior curvature more steep. So that's why you get a hyperopic shift. But when the peripheral edema resolves, this hyperopic shift goes away. This study published back in 2013, they looked at the outcomes of cataract surgery following DMEC. All eyes achieved 20/30 or better. They had, and were within the plus or minus 0.5. The cell loss was pretty similar to what you see with standard cataract surgery. So these are basically the options in Fuchs dystrophy. You can do a cataract surgery alone, followed by endothelial keratoplasty. This is a nice flowchart that I have for all what I have spoken, which summarizes, depending on Fuchs dystrophy, whether you have an asymptomatic or a symptomatic patient with clear lens or with a cataract, and you can plan the surgery depending on the cell count and the pachymetry. So newer diagnostic methods quantify corneal changes in Fuchs dystrophy, helps us monitor progression. Choice of procedure depends on patient's expectation, how long the patient is willing to wait. And advanced techniques have definitely improved the refractive outcome. In future, the cell therapy where you culture the endothelial cells and inject into the anterior chamber, that's a definite possibility, and it will change the way we manage Fuchs dystrophy in future. Thank you for a patient hearing.
Thank you, sir, for that masterclass on managing cataract and Fuchs dystrophy. Just one doubt or one question, sir. If you if you have planned possible sequential, that cataract, and let's see how things goes, if it
Correct.
decompensates, then in those cases, do you post-operatively give Rho kinase inhibitors or any other suggestion?
See, the Rho kinase inhibitor will only work. The Rho kinase inhibitor helps speed up the migration of the cells from the periphery to the center. But if your center part in Fuchs, the dead cells are still there, by adding Rho kinase, it will make that epithelial edema worse. It will give rise to what is called as a honeycomb epithelial dystrophy, where you will get thickened epithelial. Patient's visual acuity will actually drop. But if you have significant amount of healthy cells in the periphery, then a Rho kinase can work by allowing these cells to migrate to the center. But a lot of times when we see patients for DMEC, they actually come back earlier for DMEC because their vision drop is more with the use of Rho kinase.
Just one question, Dr. Fogler, by the time Shail is getting ready. What is the future of endothelial cell transplant? I mean, will we see it in the near future?
It's already in the commercial planning. CorneaGen, or earlier SightLife, they're already in tie-up with Dr. Kinoshita, and just once it clears the regulatory guidelines, it will be available. Human trials have already been done, and they have enough data for 5-year follow-up. So it's already in the commercial process. Maybe in the next COVID time, it got a little delayed, but I think in the next 1 or 2 years, you'll have a product that's already available.
Thank you.
So is phaco safer, say the cataract is not very hard, because you are far away from the cornea and not much of instrumentation?
It depends on how carefully you do your surgery. There are surgeons who can do an SICS equally well, you know. So it,
Same way I'm asking, is scleral tunnel better for phaco because you are not touching the cornea?
yes, scleral tunnel you can do depending on if your anterior chamber depth is okay, but if your anterior chamber depth is shallower and you go for a scleral tunnel and then you have the iris prolapsing through the peripheral, that can make it more difficult. So I think this is a clinical judgment you'll have to take depending on the anatomic factors and experience of the surgeon. Because phacoemulsification, if you do in the back, definitely is much safer. You can, do a controlled emulsification of the nucleus and minimize the trauma to the endothelial cells.
Because some amount of rubbing will be there, sir, in SICS. We rub the cornea,
Well, if you ask SICS surgeons, they say that
whatsoever we say.
So I'll be discussing some of the things that we find useful in managing a traumatic cataract. We receive research grant support from Alcon Laboratories. This was a 17-year-old male. Most of these trauma cases are relatively young patients with a total cataract and anterior capsule split, and lens matter was already in the anterior capsule, in the anterior chamber, as you can see. And the iris, there's a synechiae through the lamellar corneal wound. The iris has stuck here. Fortunately, UBM did show us that the posterior capsule is intact all around. That gave us some confidence while starting the surgery. So the first thing that we want to do is to try and make sure that whatever opening is remaining whatever capsule is remaining on the anterior side, we try and convert it into as much of a capsulorhexis as much as possible. So you create a nick. This entire area is the open area. So this from here to here is the open area with synechiae. So we created an opening. This being a soft, fluffy cortical matter, you go ahead with bimanual irrigation aspiration, particularly in such case, so that the collapsing of the chamber is reduced as much as possible. And always, while changing hands, you inject dispersive viscoelastic. So now we have a situation where you have a half open anterior capsule, you have an intact posterior capsule, and the most logical thing would be to go ahead and place a single piece IOL or a 3-piece IOL in the bag. But the problem that we have quite often seen in long-term follow-up of these patients is that many of them do very badly with post-operative inflammation. And therefore synechiae formation, optic capture occurring with the iris, so on and so forth. So we thought if there's something that we can think of doing more to try and prevent the post-operative complications in such eyes, and with the experience of posterior capsulorhexis and optic capture in pediatric eyes, we thought let's consider this situation. So we've created a nick in the intact posterior capsule, and we are going ahead and creating a posterior capsulorhexis where actually there is no PCR. So something which is contrary to what we would, when we are starting the surgery, we hope that the capsule is intact, and we got that, but still we want to try and make a largish posterior capsulorhexis, so that we can go ahead and plan an IOL in the bag with the buttonholing of the optic through the posterior capsulorhexis. So after having done that, I realized that I need to also enlarge the anterior capsulorhexis to an appropriate size, and further extension of the posterior capsulorhexis, so that the rhexis is large enough size for the optic to pass through it. So now we have this large enough anterior opening and a fairly decent size posterior capsulorhexis opening. And of course, 3-piece IOL is the IOL of choice when you are thinking of any form of optic capture. So our aim is to try and place the haptics behind the anterior capsulorhexis. So whatever bag is there, here the area is open, so we do expect that the haptics may come up. But we are pushing the optic, as you can see here, through the posterior capsulorhexis. So the optic is now going to be locked in that position, away from the iris, away from the anterior capsulorhexis structures, and is going to remain very stable. You must always make sure, however confident you may feel that you have not disturbed the vitreous, always confirm by injecting preservative-free triamcinolone acetonide. And fortunately, there was no vitreous disturbance in this case. So why the principle of optic capture? Because it first of all helps to fix the IOL at that place and therefore gives superior stability. Thanks to my colleague Dr. Samresh, who has made this wonderful experiment to show that when such open eyes, the IOLs are likely to move post-operatively. Compare that to an optic capture, where whatever happens post-operatively, the IOL position is not likely to change. And the other, like you see here, this post-operative picture, this dumbbell sign is a sign that the optic is captured through the posterior capsular axis. And the other advantage is that because the anterior and posterior capsules are leaflets are fused, visual axis obscuration is never going to occur in this individual. Another case, a firecracker injury before 2 weeks. Again, a similar situation of a split capsule. As you can see, half of the capsule is open, lens matter in the chamber, synechia to the lens matter, and the iris is also completely distorted. Once again, after lens removal, we follow the same principles. The posterior capsule was intact, but we decided to create an opening in that intact posterior capsule and attempt to create a decent size posterior capsular axis. Here I'm injecting a cohesive heavy concentration viscoelastic Helon GV in this case with no financial interest. I'm going behind the capsule so that there's a space that is now created between the posterior capsule and the Berger space, so that I inadvertently don't grab the vitreous with my forceps while I'm trying to catch the capsular axis flap. So I'm using all side ports from all different angles so that the traction is minimum and we can get the best ergonomic comfort to make the posterior capsular axis. And once the optic was captured through the posterior capsular axis, we also decided to address the pupil in this case, which quite often in many of these situations is damaged. So this is the technique that Dr. Amar Agrawal sir and Dr. Priya Narang have taught us, the 4th-row pupilloplasty, where you just bring out this loop and through that loop you pass it 4 times and tie it. In the end, always make sure that you have no vitreous disturbance, which we felt, and as you can see, the cornea did have stromal edema pre-existing. But look at this post-operatively at 1 year. The eye is extremely quiet, the optic is way behind, and the pupil is also doing quite well. So there are no cells on the IOL, there are no pits, no iris pigments, so on and so forth. So we have found this principle of optic capture in pediatric or traumatic cataracts to be very useful in achieving good long-term outcomes in such eyes. Thank you so much for the patient listening. I would like to thank the audience in this lunch hour to be attending a course. We are, I think, through our time. Just before we conclude, Dr. Fogla, we had a presentation on cataract with pterygium earlier on. And what would be your preference if you have a significant pterygium with a cataract? How long do you wait after pterygium surgery and a gap between sequential pterygium and cataract, and your preference? A month. Is correct. Stable. Very true.
For your presentation, excellent. What I wanted to ask you is that in that scenario, what kind of surgical skill that a surgeon should have? Because you have a trauma, you have a break in the anterior capsule, and you're venturing out to create a capsulotomy, a large capsulotomy in the posterior. If you goof up there, then you're lost. Neither can you place a lens.
That's very true. I think so. The first thing is that this should not be a first case for attempting a posterior capsular axis. So you should be fairly, I mean, you should have some experience of doing a posterior capsular axis. And these eyes, generally being young, they behave fairly similar to a pediatric capsular axis. So one is that. Second is, yes, we must have a backup plan. So if things were to go wrong, if there was vitreous disturbance, I was prepared with plan B that I may need a pars plana vitrectomy. I had my colleague Dr. Shamal on call that if we require, you may need to come up, we may need to even go for a scleral fixation or some form of intrascleral fixation. So plan A, plan B, plan C preparation is also very important.
The type of viscoelastic, and you used a microcapsular.
Yes.
Do you think that
Yes, I think the type of viscoelastic is crucial, and our preference is either Helon GV or Helon 5 because not only are they cohesive, but they are of a higher concentration of sodium hyaluronate, 1.6 or 2 gram. and therefore they help to flatten and keep things much more. And micro instrumentation has really changed the way we can approach. And don't try to use the main wounds. Use the smaller 1 millimeter. Make as many paracentesis as much as required from wherever you want to reach. Use those paracentesis incisions. We never tried staining it, yeah.
Yeah, just one last question, if time permits. So when you do a posterior capsular rhexis, do you always do a little bit of vitrectomy, or you just do only if there is a vitreous prolapse?
No,
Just for the audience.
Yeah,
to know.
so in an adult situation, we do not do a vitrectomy unless there's a vitreous disturbance. We only do a vitrectomy if there is vitreous disturbance that occurs. And we have shown that even in pediatric eyes, even less than 6 months of age, if you are able to achieve an optic capture, the outcomes are as good without vitrectomy as with vitrectomy. So thank you very much once again to the audience. Thank you, Dr. Fogla and the faculty, for being a part of this course.